right, thank you everybody for coming. My name is Paulo. I'm the marketing director of VSGi. We have a great team from Poly here to talk about grants and the healthcare. And with that, I'm going to send you to Brendan Murphy. Thank you.
Thanks, Paulo. Greetings, everyone. My name is Brendan Murphy. I'm the sales director for VSGi. I just want to give you a quick introduction to who we are. VSGi is a nationwide AV integration firm with a focus on collaboration technologies. We've been in the business for 30 years, servicing thousands of customers across the country in all verticals, including commercial, federal, healthcare, education, and many more. We take a product agnostic consultative approach to ensure that the custom solutions we develop for each customer is based on their objectives, not a list of products we try to shoehorn customers into. Our award-winning engineering teams have been recognized for accomplishments in both the design and implementation phase, as well as our ability to support our customers after for the life of their technology investment. We have a proven track record of designing, installing, and supporting technology solutions for our customers in a wide range of environments, from basic video conferencing cards to fully integrated conference and boardrooms, to comprehensive global digital signage deployments, to full classrooms and auditoriums, and all manners of peripheral devices. We maintain the highest level certifications with the top manufacturers in the industry, which allows us the ability to recommend the best solution for each customer. It goes without saying that 2020 was a year like no other. While circumstances presented a host of challenges never seen before, through some of those challenges, we found innovation. One area in particular was in regards to the way that we utilize technology to bridge the gap of an increasingly virtual world. Collaboration technologies in particular were thrust into the spotlight as they took on a new importance in ensuring our ability to stay connected, to continue driving business forward as close to normally as possible, and to ensure the ability to effectively communicate even though we were all physically separated. In no vertical was this felt more so than in healthcare. Hospitals, clinics, and healthcare organizations of all kinds were forced to pivot very quickly to new methods of communication to ensure that they were able to continue to deliver quality care, to continue to provide CME, and to ensure as few interruptions to business operations as possible. Video conferencing technologies were at the heart of this movement, and we expect that to continue. This new modicum of care is quickly becoming commonplace as doctors and clinicians are more adept to interacting with patients over video, and as patients are becoming increasingly more comfortable receiving care virtually. The good news, the government recognized early in the pandemic the need to reduce the restrictions around reimbursement for virtual care, and with that, recognized the need for healthcare organizations to be enabled with the necessary tools to be able to effectively deliver quality care by utilizing the tools that allowed for the collection of both objective and subjective data when interacting with the patient. As a result, the government has opened the doors to funding through various grants and programs like never before. That's why we're here today, along with our friends from Poly, to help provide guidance to you and your organization to navigate the process of identifying the appropriate programs, assistance in applying for these programs, and consultation on what technologies to invest in once grants have been approved. With that, I'd like to introduce Jennifer Walker, Poly's Channel Grants Manager. Jennifer and her team are here today to discuss how Poly can assist you. Jennifer?
Hey, thanks so much, Brendan. It's great to be with you today. So I have the real pleasure of introducing Cheryl Henshaw today as well. She's joining us, but I want to tell you about our company. We're with Learn, Design, Apply. So while I am Polly's channel grant manager for the East, we're actually a third party vendor. And why that's important to you is because that gives us the ability to work directly with you, the customer. Through Poly is a value added service and in combination with VSGi. So we're really happy to do that. And what do? Well, we go find this money, these pots of money. And right now there's a tremendous amount of it, thanks to the COVID relief stimulus programs. And there's traditional grants as well. So there's all kinds of foundational grants and traditional grants out there. We help find the money, figure out what's the best fit for you as the customer, pre-qualify you, and walk you through that process while we work through VSGi and Poly. And then we even offer post-award support when that's necessary. And that's really valuable to you. So you as the customer do not have to learn everything there is to learn and figure out everything there is to know about a grant. So it is my pleasure to introduce Cheryl. She is the president and founder of our company, Learn, Design, Apply. She has over 20 years of experience with this funding, and you're going to love hearing what she has to say today. Over to you, Cheryl.
Thanks so much. Yeah, so I'm going to talk to you a little bit about some healthcare funding, although like we've all alluded to, there's so much funding out on the street right now. We could never talk about all the programs available, but we'll hit the highlights of a couple of great programs and talk about what we see coming in the third stimulus. So, our concept that Jen was talking about is really a follow the money approach, right? So we really feel like when there's abundant funding available and, you can identify what vertical segment you're focused on and you understand your use case or your needs, and then you find solutions to address those needs. You work with your channel partners to go, can you deliver those products or services with me? And really articulate your program. That's kind of where the magic happens, right? So we're very much about following the money and helping you find the funds you need to kind of implement and grow your vision. So the first program we're going to talk about today is one that we think will be coming out anytime now. It's the FCC COVID-19 telehealth funding. I always call it a grant. It's not technically a grant. It looks and feels like a grant. It's competitive. And there is a narrative portion. So really acts very much like a grant program, even though this is managed by USAC under the FCC, which is more of a kind of, we're going to give you a reimbursement on your telecommunications costs, fill out this form, follow our rules. And if you do that properly, we're going to fund you, right? Oops. So this is a little bit different in that they're going to measure, like what is your need as it relates to COVID? How do you stack up against other people? That sort of thing. To be eligible for this funding in the first round, you had to meet certain eligibility criteria, and, you could kind of see those 8 criteria there, but essentially, you need to be a nonprofit or a publicly eligible healthcare organization. You can't be a for-profit. That's the big limitation there. We do believe that the eligibility will apply, that same eligibility will apply in the second round. So just like the first round of funding, there's going to be $200 million available. Now, I know it says in the Act, in the Consolidated Appropriations Act, there's $250 million available. That's true, but they're going to carve $50 million off for administrative purposes. So $200 million available for awards. In round 1, there was an award cap of $1 million. The FCC is now kind of considering, well, should we keep that award cap, or should we allow like larger healthcare organizations who, organizationally have lots of clinics or their hospitals associated with them, since they're larger and have bigger reach, should they be able to apply for more money? They're also thinking about things because they ask for kind of a list, a request. They put out a request for comments, and they basically said, here are all the things we're thinking about as we, start to put out round 2. So you kind of get an idea of where they're going with the second round of funding. So, one of the questions is, hey, should we have another rolling application window? Or should we say, hey, here's the first date you can apply. Here's the end date you can apply. At that end date, we're going to review all the applications. We're going to compare you to one another, and then we're going to put out a comprehensive awards list. Because the intent of this funding is to get on the street as quickly as possible to address COVID, I am so hopeful they're going to do another rolling application period. It makes sense to me. They didn't ask for my opinion personally, but that's what I think they should do. Another thing they're considering is, if you receive funding in round 1, can you apply for funding again? And even further down that road, hey, if I applied and got funded for, let's say, 500,000, so I haven't reached that 1 million cap, should I be able to go after the other, 500,000? I really think if you go back to the intent of the funding, and they very clearly say, we want to provide this funding to areas that are the hardest hit with COVID, how do you not fund somebody who's still providing those vital services, who still has those needs, but again, my personal opinion, not what they're going to come out with. So we are waiting on them to put out the new set of rules. We don't really think it's going to change significantly. I am hopeful they're going to change some of the things that have to do with the application, because the application guidance last time was super vague. They weren't very clear at all about what they expected from you. And in fact, people submitted their applications and then they would lose their place in the queue to be reviewed because the FCC would come back and ask for questions that they never even addressed in the, in the portal, right? So we learned a tremendous amount during round one. We anticipate the same thing happening in round two. And please count on us to be a resource for you. What we found, because we work with healthcare organizations across the country, large and small, very different geographies, what we found is that, we were hand-holding people through this application process, and it was admittedly new for everybody. So, we'd be on a Zoom call like we're on today, and they'd be sharing their screen as they got into the portal, and we'd hit a road bump. But we'd navigate around, we'd figure out a workaround. Or, somebody would go ahead and submit their application and a question would come back from the FCC, and we'd go, oh, okay, they never told us to answer that question, but here it is. And so as that was happening in real time, we were compiling that information and just constantly updating kind of a set of guidance that it actually went viral. We started getting calls from all over the country going, hey, we saw your guide. Can you help us? Can you answer questions about this? And that's what we do. So I don't think Jen mentioned this, but our services are a free resource. So there's no strings attached. There's no charge. We do this for anybody who wants a little help and guidance. So we had tremendous success with round one. We got almost everything that we touched funded. So please feel free to reach out to us, ask questions, ask us to jump on a call with you. We are happy to help you through this process. So I want to give you an example of something to think about as you're starting to pull your applications together. We know that they're going to be considering, like, what are those hardest hit areas, and how do we measure the hardest hit areas, right? And that's very subjective. And so in grants, I hate to use the word spin, but it's a little bit like spin. You want to cite the source that makes you look the worst, because in grants, bad is good, right? So the harder hit areas, the areas that have the most problems, are, or serve the most challenged population, right? Those are the ones that are probably going to be prioritized for funding. So one of the examples I like to use is like these COVID heat maps, right? So if you look at the pink map at the top, this is just total number of cases, right? And so you can see like the concentrations of blue area, mostly over there in California. Like if you just looked at this map, you'd go, ooh, if I'm in LA, man, I'm getting funded, right? If you look at the green map below, that's the number of deaths, total number of COVID related deaths. Those things align, like they overlay very well, and it kind of makes sense. If you have higher cases, you're probably going to have higher number of deaths. But if you look at the blue map there, that's the number of known COVID cases per a population of 100,000. So now look at the US, right? Look at all the blue areas. Like the picture completely changes. And like right now, if you were in South Dakota, you could go, oh, I could have a pretty good chance of funding if I use this source. So my point here is that cite sources that are going to make you more fundable, right? So you want to very heavily document your problems and cite your sources and make your comparisons so that your project has a better chance of being funded. And we can definitely help you with that. So there are definitely things while we wait for the guidance to be posted that you can do right now, right? So if you don't currently receive discounts on your telecommunications through the FCC, like through the Rural Healthcare Program, then you're not going to have an FRN. You're not going to have your eligibility or 460 determined yet. Even though that is not a requirement to submit, it does take time on the back end. I would do it now. Like there's nothing to stop you from doing that right now and just getting your project teed up, right? And getting your eligibility established. I would also start thinking through my project and determining your telehealth needs. This grant is all about telehealth equipment, licensing, peripherals, things like that. That's it. No services, no operational costs, no personnel. It's a telehealth grant, right? So start thinking through what those needs are. And that's really going to be dependent upon your project. So is your project about direct COVID response? Like, are you doing COVID detection and treatment? You may need completely different kind or quantities of equipment than if you were going to do something, say, associated with indirect COVID telehealth, which means, hey, I'm going to keep patients who need, let's use chronic care, right? So, diabetes or cardiac care, things like that. can I do telehealth to the home and keep them out of the hospitals where there's opportunity for viral spread? That's something that's certainly eligible in this project, but it's probably different types of equipment or different quantities. So think through what it is you want to accomplish, or, maybe it's a combination of both, but go ahead and start identifying, like, who am I serving? How many people am I potentially serving? How many patient encounters am I likely to have? And then think about how that would align with the budget and make sure your numbers match. So, if you said I'm serving 200 total patients and I need 10,000 licenses in my budget request, somebody would come back to you and go, hey, those things don't jive, right? So make sure your budget matches what you say you're going to do and the numbers of people that you say you're going to serve. Then once you've kind of determined that, I would work with a vendor like VSGi to go, hey, can you make some product recommendations for me? Can you go ahead and quote this out so that I'm teed up and ready to go when this grant hits the street? And then last thing, in round one, services were not eligible. So like installation and maintenance was not eligible. And so the interesting thing, and it's in the language for this round too, they've waived kind of the for free requirement. So it's possible that somebody could go, I'll give you an example of licensing. Let's say you wanted a year's worth of licensing because it comes in a 1-year bundle, but if like round one, they limit it to a certain number of months, in round one, it was 6.5 months is exactly what they would pay for. They prorate it out. They take that annual fee and they prorate it down to where you got the amount to cover the 6.5 months. So, theoretically, you could have gone to someone and said, hey, can you create some sort of bundle where I'm going to pay for the 6.5 months and you give me the other 5.5 for free, right? And that would be completely okay in this scenario. In this grant as well, or sorry, this funding source as well, they've waived procurement requirements on the back end. So that doesn't mean you don't have to go through procurement. It just means the FCC isn't dictating that to you. So as long as that's okay with you internally, or, if you're like a state or local organization, always, defer to your procurement office, but the FCC is waiving those requirements. And that's a nice thing. It just allows you to get your project started very quickly. There we go. So beyond the FCC COVID-19 funding, my favorite grant, the DLT grant, Russ Distance Learning and Telemedicine grant, should be out sometime in the next couple of months. Normally, it would already be on the street, but we are in an election year and we're in the middle of COVID and things have just been delayed because of that. But certainly, this is a fabulous grant. It is also like a capital expenditure grant. It's very focused on providing the equipment, the software, and the services that are associated with distance learning or telemedicine. Now, by distance learning in this grant, it's a very broad connotation. It can be like public health, education, it could be mental health, it can be substance abuse, it could be school-based health, it could be any flavor of primaries, specialties, subspecialty care, whatever flavor of healthcare that you're interested in, this grant will pay for, as long as you're focused in rural areas. So delivery of the benefits into rural areas. You can be downtown Manhattan providing these services. Your demographics don't count against you, but the people receiving the benefit, receiving those services, have to be in rural areas. So we think this grant will be out probably in the next couple of months. So watch for it. Really good idea to get prepared before it hits the street, because this grant is kind of a monster. And see, it makes me go, why is it my favorite grant if it's such a monster? I'm not sure. I have a love-hate with this grant, but it is one that provides so many great benefits to rural areas. And really, I think when it was developed, it was all about bridging the digital divide, and that's still true today. So really provides great benefits. There is a 15% match to federal request ratio, which turns into about 13% of your total project cost. So, you're paying 13 cents on a dollar, which, what a great deal, The award size has for the last couple of years been up to $1 million. So again, TBD, there's $60 million right now that we know of allocated to this program, although they sometimes do add more money to the pot. They do change their special consideration or priority points every year. There's 10 total. You get it or you don't. You can't have multiples. But those in the past, for the past couple of years, have been focused around STEM, or opioid or substance abuse more broadly, and then if you're in an economic zone. So again, we're going to wait and see what they come out with this year. And who knows, it could be COVID related this year. You never know. That's the thing that changes most often, is just those special consideration points. You do have to submit via grant.gov, and you have to have a SAM registration. But beyond that, everybody can apply for this grant, just about. So you can be for-profit, nonprofit, state and local. I mean, you name it. You can't be a federal organization and you can't be a sole proprietor, but just about everybody else can apply. So really fantastic grant from that standpoint. It's so very exciting. If you can even believe this, we just had a new stimulus approved the end of December, and now we have another one coming very quickly that will have more money coming for healthcare. So you can see that SAMHSA and HRSA together will receive reported $4 billion. And that's likely going to be associated with, substance abuse, mental health projects, telehealth projects, health professions projects. Those are the types of projects that HRSA and SAMHSA generally fund. So $4 billion is a whole bunch for those two federal agencies to receive. So, more details to come on that. So I'm going to take these slides down for a second and introduce my buddy, Scott Simmons, who is Polly's healthcare expert. We're so lucky to have him. And I say this all the time, the funding and even the technology is kind of the cherry on the sundae. What's important is the use case. So how do we address needs that healthcare organizations or the populations that they serve, how do we address those? And, in this time of COVID, we've seen such a dramatic change in telehealth, because of like licensure, reimbursement, HIPAA, things like that. So I'd like Scott to just comment on those things, and then maybe tell you a little bit about some of the products that that might be a good fit for your FCC grant.
Okay, so thank you for having me with you today, Cheryl and Brendan. So were you asking me about the applications, or more about, or more broadly, including the legal and regulatory changes and things like that too?
Well, start there. Start with the legal and regulatory. I mean, you use this phrase that I love, the fact that we're in a black swan event and how that has dramatically changed healthcare. I think that's
it's interesting, and I apologize to those who've heard this already, but I've been in the telehealth world for a little bit over 30 years. And, at least for the last 25, I've been saying, this is the year telehealth's going to take off. And it was this black swan event of COVID that finally made that happen, right? And I joke with my wife that, now that her mom, my mother-in-law, knows what I do, because she's actually had to have telehealth visits now, right? So we've arrived when my mother-in-law knows. It's interesting. So telehealth's always had this promise of transforming healthcare, and, both in terms of access and providing care at times and places that are convenient to the patient instead of what was convenient to the provider. But we've always had this roadblock of these legal and regulatory problems. So under the national emergency, a bunch of these barriers got dropped. So first of all, being the reimbursement. And so the big part of reimbursement is parity, right? So in other words, if I provide a service virtually, I get paid at the same rate as if I provided that same service locally. Now, obviously, there's procedural things in that I can't bill for, because I'm not providing, I'm not doing surgeries remotely and things like that. But something before that might have been the same thing if I went to the doctor's office and parked and waited in the waiting room and finally got seen for 10 minutes. But the physician got reimbursed $80 because I went there in person. I could have accomplished the same thing by a phone call or a video visit, but I was only getting reimbursed $12 if I was the physician. So that was a strong disincentive. So those sorts of, that's what I mean by parity. So it's whatever that reimbursement level. I'm just using 80 and $12 as an example. The other restriction that was removed under the national emergency was site where the service can be provided. So these eligible sites. So a lot of these services could not be provided in the home. That was waived. So that's why we saw, traditionally the direct patient visits to patients at home or wherever they were limited to primary care visits and follow up in that. This opened the door to specialty consultations, specialists directly contacting patients. So those are two of the big things. But licensing, interstate licensing requirements were waived. There are a number of those things. And I think what's encouraging is that it's likely that, we don't know 100% what it's going to look like after the national emergency is removed, but we get some inkling because the Medicare rules that were passed that went into effect at the beginning of the year are very continue to be telemedicine friendly. I think it's always forget the name of the organization. I think it's like the National Federation of State Medical Boards is pushing for national licensure. And I think there's actually some proposed legislation in the US Congress to remove to promote national licensing. And what's also happening is a number of states, and the first one I can think of is Governor Cuomo in New York, is pushing really hard for comprehensive telehealth reform in the state of New York. So that applies to the state Medicaid program, private insurers, and other things. So that's a long answer. So that's kind of the legal and regulatory kind of part of it. But I think, I do think telehealth's finally here to stay for those reasons. And now we have the other interesting thing too, is that we hope that this stays in play for a long time, because those of us who've been in the field for a long time and doing research in this area, is we finally have telehealth at scale, right? And so we can now get really good data on the cost effectiveness and efficacy and other things about telehealth that we couldn't get before just because it was so low volume. Like, I was talking to a customer the other day, and before COVID, and this was a big statewide health system, and they were doing like 600 visits a day, something like that. And the day we were having the meeting, they did 65,000 visits.
Holy cow.
So that's what, two orders of magnitude more, right? So
That's crazy.
Yeah, so it is nuts.
Well, I always find it interesting. For years, telehealth's been around, at least 30 years, right? And the VA Medical Center has traditionally been the largest telehealth user in the country, and they do it very well, very efficiently. It's very effective. Patients love it. And I've always thought, why can't everybody else take off? And I think we have had those barriers in place, specifically the licensure reimbursement. And it was so funny after not funny, but ironic. As soon as the pandemic hits, like it took 2 weeks and poof, those were gone because, just out of desperation or need or whatever. But I think it's been such a good demonstration that it's effective. Like, it's effective in reaching people and keeping them safe. It's effective in limiting viral spread. It's effective in terms of cost effectiveness. But the big one for me that I think is going to propel this change is that patients love it. Like, who wouldn't rather get on a telehealth call on your tablet or your phone or something with, your primary care physician if you need something simple? Why take off work or take your kid out of school to go into an office where, by the way, they're more likely to pick up a virus or something, right? This is just so much easier.
Well, and it might be worth me talking a little bit about some of the applications, because if we're thinking about applying for FCC grants and other things that are specific to COVID, like a lot of these programs you're talking about are COVID related.
Yeah.
Some of the things that have been successful with our customer base. So, I mentioned the direct to patient visits, that'll still be there, but the specialty care, urgent care, it's almost like a business continuity thing, right? That without telehealth, these especially specialty practices are not going to stay in business, right? So the direct to patient visit. Another big element has been remote patient visitation, and wouldn't necessarily think of this kind of classically as a telehealth application, but because of COVID, that these health institutions and nursing homes and skilled nursing facilities have just completely locked down face-to-face visitation. So a lot of our customers have used video conferencing to enable family members to continue to be connected to their hospitalized patients, right? Or their hospitalized family members, I guess you could say.
Right.
But that also can be used to support family caregivers, and I think one of the things is it really highlights the role of the family in the healthcare system. But we've had other customers that are using the technology to remotely observe COVID infected inpatients. So you imagine someone gets admitted to the hospital, they're in a COVID ward, they have to get checked on every 10 or 15 minutes, depending on how serious they are. But what was happening without that is a nurse or other health provider would have to put on the PPE equipment, go in there, and it takes time to do that, and then go out, right? And so amazing amount of time savings and still providing effective care. And then there's just a number of other things, being able to have a group of specialists cover multiple facilities and not being able to drive not having to drive multiple distance, but also lowering their infection risk. I mean, there's just a ton of these.
Sure. So
So kind
somebody
of things to
actually
think
in
about.
chat here asked the question, Scott, how much impact or improvement has this helped rural hospitals?
That's a good question. I think so. Rural hospitals have been on the largely because of these programs, like you were talking about, like the DLT. We're kind of ahead of the game over the urban centers. So I think that for a lot of rural hospitals, I think it was just higher volume of what they're already doing.
Yeah.
Right. But it is a challenge, right, of staying in business, because so much of the revenue that goes to a facility is based on procedures, is based on surgeries, and both inpatient and outpatient in that. But it was I think it was a lot of the urban health systems were the ones that were really struggling the most.
Well, I know with a lot of rural health center, especially way back in the day, I used to work a lot with the VA hospitals, and sometimes they'd have a local patient, he'd be with a local provider, but they'd have some sort of significant issue, right? And the doctor was just completely reluctant to refer them to the big tertiary care facility,
Right.
3 hours away. But when you could involve that local doctor with that care provider at the big VA medical center, they were more likely to refer and stay involved in their patient. And when that patient came home, there was better continuity of care, that sort of thing. So I think from that perspective, it's great. I also think in rural areas, you have the access to specialty care that's just not available in rural areas. So I've worked on so many projects where, it's always shocking to me. Somebody will say, we don't have a single health provider in our county. Like, how is that even possible? But it is, it's true, so what do you do in those instances? Telehealth is such a good way to
I'm glad you
provide
mentioned the
outreach.
I'm glad you mentioned the retention thing. That just totally,
Yeah.
I should have opened with that part, because that's so significant, right? So if it's if I can provide those specialty services remotely, if I just need a consult from a neurologist occasionally, or some assistance with a variety of different specialties, that patient stays in my facility, in that rural community. So yeah, that's a good
I
point.
think we started seeing that too. I think the paradigm kind of shifted when there was more a focus on making sure that, or trying to make sure there weren't a lot of readmissions. And so then that involved that continuity of care, right? So making sure when you discharge, that everybody's kind of informed, and you're bringing in, like you said, the family caregiver, and maybe the local doctor, and maybe the visiting nurse, or, the pharmacy, whomever. But it takes a village, right? And I mean, telehealth is so perfect for that. I think
that's
people
a big
think of telehealth as consultation diagnosis, and it's bigger, right?
Well, and the thing is, I think the unfortunate, but maybe the unfortunate thing is that the people's exposure to telehealth is so new, and they think in this limited, well, it's just these direct to patient visits. But like you were mentioning, like pre-discharge coordination is huge, especially since all this value-based payment is there now. So, you were mentioning getting punished for readmissions within 30 days.
Right.
And doing that pre-discharge planning with, including the family members in there is so huge. And the other value-based care models, telehealth, collaborative care, and other aspects of value-based care are enabled by telehealth.
Right. And it makes me think, I always tie everything back to a grant, because that's my little world that I live in. But it makes me think, I was on a call a few weeks ago, and somebody made this comment, never let a good disaster go to waste. And I would tell you that really applies in this case, where you have, let's use the FCC funding, where it's very focused either on direct COVID care in some way, or indirect, but always relating back to COVID. But the equipment that you ask for in that grant certainly can be used for lots of other things. So don't limit it to just COVID. Think more broadly and about the ways that telehealth can help you, expand your reach, or bring in, new services or whatever.
Right. Well, it's a way to fund CapEx, capital expenditures. Right.
Yeah.
And I know because I ran two different academic-based telemedicine programs, one in rural Eastern North Carolina, one in urban Miami. And that was our strategy with grants too, is we always use these capital equipment type grants to fund our infrastructure, and the grant program might have been focused on a specific clinical application, but once we once we had that investment made and it was subsidized by these grants, we could use it to expand and do all these other things that continued long beyond when that grant funding was over. So that's, I
Right.
think of it as like a CapEx or an infrastructure investment is a really good play, because these things, the lifespan on these systems is fairly long. So there's
Pretty long,
use
yeah.
for many years, right?
Yeah. Well, so speaking of CapEx and purchases and things like that, you want to talk to us just a little bit about telehealth equipment or equipment that's, that's really useful in these telehealth applications?
Sure, I'd be happy to do that. Let me share my slides here. All right, and I won't kill you with PowerPoint, audience. So I just went down a couple slides just to talk about some of our Poly solutions, obviously because I work for Poly. But we really see telehealth as being transformative in redefining the continuum of care. So providing care where and when it's needed, supporting collaborative care like Cheryl and I just talked about, bringing patients closer to home. And the other thing to think about is load balancing with clinical resources, that I might have excess capacity in a specialty in one place and over utilization somewhere else. So I can use a limited group of specialists to provide care across a broader geographic range. And I'll just hit the highlights on the products. So I'm going to kind of go through from high end to low end solutions. So we just announced in January the new Poly Telehealth Station, Telehealth Cart. So this is all medical grade touchscreen, and the 12x optical zoom. We've got this, we call the base unit of this the Poly Telehealth Station. And so there's a desktop version of it, which has a desktop mount if you want to put on desktop. It also has VESA mounts built into it, so you can mount an articulating arm, or if it's on the capsa cart, which is the kind of the Cadillac of carts, if I can still say Cadillac. I might be dating myself here.
The Mercedes.
Right, and so it's got all the what we may call the gazintas and gazautas, right? The ports to be able to connect a variety of different peripheral devices that are commonly used, and it's really made for that highly clinical setting, at the bedside, in a post-op recovery center, someplace where I'm going to need to have a bunch of different peripherals to do exams in that. And the basis of that is our coder decoder hardware unit called the G7500. Now it's integrated there, but from our standpoint, it's an integrator's dream, and this is where VSGi just shines, right? And Brendan can probably back me up on this, right? So when you've got complex installations like this one's just OR, for example, and I've got multiple feeds, or a training and simulation facility, or a large complex conference room, this is kind of the core of it. And then as we move down, we've got our video bar solutions, the Poly Studio USB, Studio X30, and Studio X50, which are these all-in-one video bar systems that have a variety of different healthcare applications. So whether it's patient rooms, either fixed, mounted in the room under a shelf, or at the foot of the bed, or on a cart, or flexible rooms that could be meeting rooms and patient rooms, or break rooms, physicians' consultation rooms, private offices, and that. And then something we just announced last week is our Poly Studio P series, which P stands for personal. So what we've done is we've released this series of products that are consumer priced, but they're professional grade, right? And so there's three elements of this. So there's the P5, Poly Studio P5, which is a really nice high-end, precision-tuned, we're saying, webcam, right? And so it's got a built-in USB port too, so we can put our dongle in there to pair them with headsets too, and it just affixes to the top of your laptop or your desktop monitor. But it's also removable too. It's magnetically coupled. One of the exciting things we're doing with the P5 is that we're going to be releasing these P5 Studio kits, right? So it's the webcam and either wired or wireless headset or a sync speakerphone, all put together in one package. And so, we pick the right audio device to pair with the work style or what the clinical application is. So you can see multiple applications of this in healthcare, whether it's remote providers or staff, in work for home scenarios. If you want to have a standard load that goes out to all your employees or your beneficiaries, for patients at home, you can imagine when discharging from a hospital, having a kit like our P5 Studio. And the other elements of P5 is the Studio P15, which is a smaller form factor of our video bar, right? So it's got the 4K camera and then all the intelligent framing and echo cancellation and acoustic fence and all these really cool noise block AI features we have built into those. So it's like a studio experience. That's why it's called Studio. And then something else, which is Apollo Studio P21, which is basically a video conferencing enabled monitor. And really it's like a studio in a flat panel monitor kind of form factor. So it's already got the camera and mic array and all that, but it's also got lighting built in. And all of these work with any app that you have because they're USB devices. And it can be used as a dedicated display. Sorry, it's, as a secondary display, that's what I'm looking for. So if you're not using it for video conferencing, you use it as a monitor display. So that's just an example of some of the Poly stuff that's working now that all would be eligible under these different programs. So we'll go back to
Yes,
video.
it's all
I'll stop
based on
sharing
the proposed use case, right? So
Yep, absolutely.
So yes,
So
some of those were really appropriate for home health. Somebody had asked a question about home health. Those, some of those would be perfect. Some would be perfect for a provider from home. I think the one integrated with the display would be perfect for maybe a mental health or substance abuse provider, so lots of options there. The other thing I think is interesting about the products now, I mean, again, I'm going to date myself, but 20 some years ago when I was working with the VA, the idea of doing home health, it was cost prohibitive. It's very expensive, right? The price point and the plug and play ability, is that even a phrase? Anyway, they're so easy to use, right? You seriously can just plug them in. It's not complex. I think my mother could do it. That's my gauge for anything. Yeah. And so I think now you've made that shift to make home health, much more attainable.
Well, yeah, because the telehealth isn't one thing, right? It's so broad. Right. It's the whole spectrum of care. So if you take the patient's journey throughout the health system, whether it's like I always think of even think of a surgical one. You can do your pre-op assessment virtually before they ever come in. There's a telehealth application when they're in the surgery themselves, whether it's surgical pathology or consultation on complex procedures, and then they get discharged to the immediate post-op recovery area. And then to their room, then before they get discharged is pre-discharge planning, and then they're in the nursing home or home. I mean, you walk through that whole journey, and we all have these journeys, right, that we've made, whether it's just an office visit, and you think of all the friction or all the pain points or all the wasted drive time or wasted time sitting in a waiting room. There's a simple to the very complex. And so that's what I would urge everyone to do too, while you're thinking through your grant applications and your technology investments, is what's the array of those kind of use cases and patient journeys in your health system.
Right. I think we have
amazing.
Taken up the whole 45 minutes. Jen, do we have time for Q&A?
I love it. Just a couple, but I was just going to say it was amazing, your vast experience, both of you. And I was just going to ask Scott if he ever joins any customer appointments with, say, VSGi, with Brendan's team.
Oh, absolutely. That's one of my my functions at Poly, is to be a resource for both our Poly team, but for all our channel partners. And
Wonderful.
Brendan and I have already had several meetings in that, and so absolutely.
That's so great.
I'm here as a resource, just like we have the PGAP as a grants resource. I'm here as a telehealth and health collaboration resource too.
We're so glad, because it's obvious that you could expand the vision and help a customer really understand the depth and the breadth, and it's so exciting. Cheryl, one quick question. Somebody asked, well, you did cover some the Rusty LT that covers the for-profit entities as well when they qualify, and are there other grant programs that are for for-profit entities as well?
There are. They're fewer and farther between, obviously, but yeah, there are grant programs that are focused on for-profits. Well, I think the best thing I could advise you to do is, if you'll email us at grants@poly.com or contact your VSGi account manager, and they can get back to us. We can get a better understanding of who you are, what your focus is, what you're trying to do. Grants are always very targeted, so once we kind of understand that, we can search for a grant that's a good fit for you.
And the thing, we just didn't have enough time to cover all this. There's also a number of private foundation grants too that are are really mission specific.
Right.
And the nice thing about private foundation grants is that usually the burden of doing an application is a lot smaller than on a federal grant, right?
They're
that's
often
another
relationship
channel.
based, which makes them a little
Yeah.
bit trickier, but yeah, for sure. That's always
And
an option.
And an offshoot of that question is if a for-profit company is considering setting up an eligible entity to receive funding, if they're already walking down that path, would this be a good time to do that?
Yes, yes, yes.
Yes, that's what I said. That's
Absolutely.
great. Okay, and the closing thought, you are amazing. We could obviously sit here for hours. More than one person has asked if this will be recorded and how that will be distributed or posted. So I'm going to leave that to Brendan and Paolo as we close up. And thank you so much for your time and expertise today.
Thanks for having us today.
Thanks. Yeah.
Yeah, that's an easy one. Absolutely. After this is concluded, we will make this available. We'll email a link to everyone to the recording. Plus, we'll make it available through our website and through social media. So we'll make sure that that is made available to everyone.
Awesome.
That reminds me, I was going to share the landing page. And so let me do that quickly if I can find that. Isn't that amazing? Emails are coming
And
in. I
while
can't
you're
see my screen.
while you're looking for those, there was a few questions that were specific to which we touched on a little bit here and there in terms of specific types of care and their ability or eligibility for different programs. As suggested, there are so many programs out there. We'll follow up with each of you guys and have a more direct conversation with you about your specific needs. So if we didn't address your exact question here, we'll make sure we reach out to you directly and help you.
Thank you so much. There's the landing page at vsgi.com, and you can see there's some resources you can enter to get some more information. And we thank you for your attendance today.
Thank
Thank
you
you,
so
everyone.
much.
Thanks, everybody.
Thanks. Bye-bye.